Hi, this is Dr. Jeff with Recelebrate here at Biohacking 12 Beyond Conference in Austin, Texas. Happy to have you, and I hope you're interested in the actionable longevity interventions using stem cells, exosomes, and peptides, all the best in cell signaling, all to help slow aging. So who am I? Well, I like to use AI, as you can tell from this photo, but I'm a recovering spine fellowship neurosurgeon, always looking for natural, non-surgical things to do for people before they consider drugs or surgeries. I've been practicing regenerative medicine, peptide medicine with a focus on the musculoskeletal niche, but much more, and I'm a biohacker myself. But the restorative assistance from stem cells and stem cell-derived exosomes and peptides is huge. And we speak to this as regenerative medicine, and it's really the ability to learn what we have from how you make a baby and take that strategy to apply that youthful biology to someone who might be older or inflamed or having cellular problems to get them back into a more youthful, less damaged restorative state. We call that cell signaling for longevity, and this is how we encourage the cell activities, the proteins being made, the genes being called upon to work in that anti-inflamed peacetime state, not the inflamed, wartime state that our cells have become accustomed to in a world of electromagnetic fields, pesticides, preservatives, microplastics, bad thoughts, you name it. We call this sometimes cell metabolism, which is a sum of all the different pathways that are taking part in a cell at any one time. And we want to focus on the less inflamed pathways, the ones that actually anti-inflame us so that our cells work at their best and most youthful way. And that optimal state is when cells can do what they're supposed to do. And when we do that, we are more youthful and we can live healthier longer. And we like to do this kind of signaling without drugs, without surgery, without steroids. So if anti-inflammation is all it took to be younger, why don't we just take a bunch of Motrin or Advil or Aleve every day, a bunch of anti-inflammatories? Well, that only works on one pathway, and there are so many redundant and conflicting pathways in the cell, it just doesn't work. So how does all this work? Well, let's start with the stem cell, because we've all heard of these, and we used to think they were actually regenerating us, but turns out they're not. They're signaling our cells to do the work. So where do we get stem cells and other biologics from stem cells? Well, I get them from youthful donors. I mean, these are mothers who just have a C-section baby. Congratulations, healthy baby. They're screened ahead of time. They've never had the COVID vaccine. The mothers haven't had the COVID vaccine. And we take their amniotic fluid, umbilical cord, and things they're done with. So it's ethical, it's moral. It's a regulated process through tissue services, tissue donation services, just like a kidney transfer or a kidney transplant. And also, it's regulated through FDA-registered labs. I mean, this is a very official and regulated thing. Now, you could take stem cells from your own body, from your bone marrow, from your fat, from other places. But I don't know about you. When I take my car in to get the oil changed, I want some fresh new oil so it runs best. So I like the more youthful stuff. That youthful stuff has not been exposed to inflammatory stress and damage. But I noticed this way back in my residency in the medieval times, Middle Ages, that we were doing surgery on babies in utero for spina bifida. We would close the spina bifida and they'd have a better outcome. But when those babies were later born, having had surgery in the middle of their pregnancy, those babies would sometimes have no scar or minimal scar. So there's something magic that we knew at that time about the amniotic fluid. And I wasn't the first to notice this. A group in 1992 out of UCSF noticed it. They weren't sure what was causing it. They didn't know all the constituents of amniotic fluid at that time. But they knew something was very interesting about amniotic fluid. So a few years back, I said, well, let's go back and study that. Maybe we can put that to work. So what's in there? Well, abundant stem cells from the umbilical cord source, proteins, peptides, and collagen, growth factors, and extracellular vesicles. You find all that. And those extracellular vesicles are from the stem cells. Now, you also may know that if we gave you stem cells in your vein today, those cells will be gone in a day or two. Sometimes they can last a little bit longer, but the whole thing is those cells are gone, the benefits continue to last. So we know the cells aren't doing the work, they're delivering the message. So what is that message? What's imparting that chain of evidence of information, of influence, of encouragement to our cells who end up doing the work? Well, that's what we need to learn about if we want to use that for longevity, and that's cell signaling. Cells communicate with each other. They do so via peptides, which are small proteins and growth factors. Some of those are called hormones, the smaller paracrine hormones, and vesicles, small outbubbling of the cell with a little bit of membrane. That's about 1/1000th the diameter of a cell. Since cells are measured in microns at 10 to the minus 6 meters, these are vesicles measured in nanometers, 10 to the minus 9. So sometimes they're called nanomedicine or nanoparticles. And they outbubble from a cell through a process called exocytosis, you might remember from high school biology. And those are thousands of them from a cell are carried to neighboring cells. So they communicate with each other. Those neighboring cells take that vesicle in through endocytosis. So it merges with the membrane, shares membrane, and the contents of that vesicle, called an exosome, are shared and influencing what's going on into the recipient cells. That's how these stem cells deliver to us. So why do we need the stem cells? You don't. You can go right to the message in the exosomes and the peptides. All cells make exosomes, by the way. When we use the word exosomes, we're typically talking about stem cell-derived exosomes. And these are active mesenchymal stem cells or medicinal signaling cells that are changing our cell activity into that anti-inflamed optimal state. We need that. We like it. It's for longevity. It's for health. It's for so many things. Where else do you find exosomes? Well, in platelet-rich plasma, if you've ever heard of that, in stem cells themselves, and from amniotic fluid. Now we're back to the amniotic fluid. We also see peptides in that transfer of cell-to-cell information, that cell signaling. All cells make proteins. Some of the smaller ones we call peptides, and they signal cells either on the cell surface or inside the cell, also through all kinds of different mechanisms. There are bad peptides, pro-inflammatory. There might be bad in the long run, but they can be helpful if you're under attack. If you have an infected cell telling its neighbors, hey, get ready to fight, get in inflammatory mode. There's a reason for acute inflammation. It's that lingering, smoldering, chronic inflammation that ages us. That's what we need to signal against. And you can find peptides in PRP. You can find them in stem cell preparations. You can find them in amniotic fluid. And it can also be in a vial that you purchase online. So let's talk about the exosomes first, then we'll come into the peptides. So the mesenchymal stem cell or medicinal signaling cell derived exosomes are available from donors in the U.S., fully screened and tested, and they're from FDA registered labs, and the ones we choose have come from mothers that have not had the COVID vaccine. They're highly screened, safe. I use them on myself, my family, my patients. Now remember, stem cells, if we gave those in your vein, those are preferentially taken up by the heart and lungs. So your body doesn't get a lot of them in an IV, whereas the exosomes are fluid. They go everywhere equally, and they even are small enough to cross the blood-brain barrier, which we love since stem cells are not. Exosomes contain microRNAs that signal our own protein production. They also contain small peptides and transcription factors that tell which genes to be called upon. They have heat shock proteins, and they have very few surface markers, so they're immunoprivileged. We let them right in, even if they came from someone else. We don't defend against them. So how do all these things work? How do these cell signaling things work? Again, they take our cells from defense inflame mode into an optimal anti-inflame restorative mode. That's the basis of regenerative medicine or cell signaling. Longevity cell signaling can use these stem cell-derived exosomes as a factory reset to our cells. Make our cells act younger. If they act younger, they behave younger. They behave younger, our organs behave younger, our bodies behave younger. And we slow the cellular aging process. We slow and reverse the biological age. I like to call this cell activation. And we know it works because a pregnant woman, think about it. She's got a baby, she's got amniotic fluid in there. She's got a bunch of cells, the baby and the stem cells floating around in her womb. Now the cells are too big to cross the placenta. And that's important because those cells are half genetically hers, half genetically someone else's. And we don't want those foreign cells to be circulating through her bloodstream. She might reject the baby. So they don't get outside the placenta. It's a protected area. But the exosomes are small enough to get out, and they don't have those markers of genetic difference. So those exosomes get out and get into her system, and guess what they do? They help her hair grow. They help her skin glow. They help her be in a good mood and feel good most of the time, getting ready to have a baby. And she should have that survival advantage because she's about to carry on the species. So that's why young mothers are glowing and have their hair growing. They're getting an exosome treatment every day. Let's compare stem cells to exosomes. So again, we like exosomes better because they are the cargo, whereas the stem cells are just the delivery of the cargo. Exosomes have no real risk of rejection. Stem cells minimal, but I like to play the difference there. Exosomes are well distributed throughout the body, where stem cells are really taken up by the heart and lungs, and the body doesn't get as much, and they definitely don't get into the brain. If you get them IV, again, the exosomes cross the blood-brain barrier. They're easier to store and handle, and they cost a fraction of what stem cells do. So they've really opened up regenerative medicine in the last decade. And our applications are abundant. I use them in my practice for cartilage regeneration, which I've spoken about in the 2 years past here at the Biohacking Conference. And you can find those talks online if you want to get into more detail, and I'll show you some examples. We use them for osteoporosis, metabolism issues, organ issues, gland issues, sexual dysfunction, like an O shot or like a P shot, cosmetic issues. We can do them for facial rejuvenation, hair improvement. We use them to help fight autoimmune. We use them for peak performance, improve your triathlon time, your VO2 max, your HRV. We can use them to help you recover from a health event like a heart attack or stroke, although it's better to prevent, and for bone density loss and muscle atrophy in the frail. Where else do you find exosomes in nature? Well, bone marrow and bone broth, and we've heard those are quite healthy. Why? Stock, chock full of the stock is in the marrow are the stem cells, and they derive the exosomes. Chicken soup. Why do grandmas make chicken soup for the young when they're sick? Because of the chicken stock, gives exosomes, helps you heal and fight and support your immune system. And then in colostrum and mother's milk. But we also know that plant-derived exosomes, for example, the Longevix or longevity exosome product is also quite useful. And here's an example of a paper on plant-derived exosome-like nanovesicles, a nano tool for disease therapy. So this isn't new. This has been out there. This is from 2024. And one of our companies, Recelebrate Nutraceuticals, does make a plant-derived exosome called Longevix. Stop by our booth and you can learn more about it. It's the only regenerative supplement on the market. It's the only exosome supplement on the market, and it's the only longevity supplement demonstrated in the preclinical studies to move the markers of cellular longevity like sirtuin-1 activity, reduced DNA damage markers, etc. And they are highly bioavailable. Plant exosomes differ from mammalian exosomes in that plant exosomes you can eat and they do not get digested. It's a hardier membrane. They do get through the small intestines. They do get into the bloodstream. They do fuse with cells, and they do deliver to cells nothing like what a regular supplement can do. So it's like 4,500 times the cellular delivery. So there are differences in their RNAs and the proteins you find, but the phytonutrients of plants are packaged in exosomes. Vitamins, quercetin, resveratrol, fisetin, all these things are packaged in exosomes. So they survive the digestion, they make it through the intestine. Also, our microbiome benefits from phytonutrients, and they take in the exosomes. They also produce exosome of their own. That's a topic for another day. They survive our bloodstream and get into the cells. This is an amazing spin and quantum leap in regenerative nutraceuticals. So these are just some slides from papers confirming what I just told you. And there are benefits to the brain, the liver, the kidney, and other organs from the significant phytonutrient delivery from plant exosomes. So remember, endocytosis, the getting into the cell, is how they deliver. This is how plants communicate with us. And remember, traditional supplements bounce around and get digested in your stomach. Very little get into your bloodstream. When they do, there's not necessarily a receptor on your cell for quercetin or fisetin, right? So how does it get into the cell? We don't know that. You do a blood test, it doesn't tell you how much is into the cell. Well, we know that with exosomes, the phytonutrient delivery is 4,500 times. Now, liposome is a synthetic exosome, but nature's already got this figured out. So anyway, take a look at that. It's a great cell signal. As I mentioned, the anti-aging aspect, this is the preclinical paper on that product. And it can replace a lot of things. So let's talk about some examples with exosomes. So forgive me there. All right, here we go. Clinical example. This is back to, now get away from the plant exosomes, back into the animal exosomes. So I mentioned earlier my niche is musculoskeletal. Do quite a few procedures with joints and spine, helping people avoid surgery or cortisone shots, which don't really do a lot in the long run, just in the short run. But I'm sure you're familiar with arthritis or osteoarthritis, bone on bone, wear and tear, cartilage loss, aka chondromalacia, or I hate this phrase, but degenerative joint disease. And it's really a metabolic disease of the cells that we have in our body that make cartilage. So we make cartilage. We made that cartilage when we were a baby. And we made that cartilage from a type of cell called a chondrocyte. And the chondrocytes live in the bone edge. They do not live in the cartilage. They produce the cartilage protein, just like a cell in our scalp makes a protein called hair. Hair is not a cell, it's from a cell. It's a protein product. Same with the cartilage. The problem is a inflammatory degeneration and dysfunction of the cells. They can no longer produce it. They're hurt, and they're a low-hanging fruit of inflammation. So if you have any accumulated inflammation, one of the earliest things you might see would be joint pain, joint degeneration. And there are stages of this. The last stage we call bone on bone. And that's when orthopedic surgeons say, well, it's time for surgery. Well, as it turns out, if you look really close on an MRI and you order it right, it has some bells and whistles, you got to order off the secret menu, you can see the white area in the cranky cell area, the bone marrow, where those chondrocytes live. The problem is in the bone. On the right is a healthy bone, nice gray, evenly colored bone marrow. That's a normal. This is cranky. You can see that white spot in the bone. So the cartilage loss adjacent to that isn't the disease. The disease is the bone isn't working well. So remember, there's very little biology in the cartilage. It's just a protein. There aren't a bunch of cells in there. There might be a few. But the main activity is in the bone, in the old growth plate there. So why do we keep injecting the joints where the cartilage is? It's sort of backwards. It's a good question. Ask your orthopedic surgeon. So when I was looking to start this about 8 years ago, I looked into the research. It says, what's the best way to do this? Where are the best results? Well, it turns out they were in Paris. And University of Paris East, Dr. Herngu took patients with both knees were very degenerated and they needed surgery. They were told they were surgical candidates. He said, hang on, join our study. And in one knee, they injected the cartilage with stem cells. In the other knee, they injected the bone edges above and below the cartilage of the meniscus with stem cells. And they watched these people over time. Initially, they all did well. 100% did well. Over time, 5 years, 10 years, 15 years, and they published this. This is a long, longitudinal study. The red group is the joint injected group. Those people started having trouble. And by 15 years, less than 25% of them were still doing reasonably well. Whereas in the bone injected group, over 80% were still doing great. So clearly the way to do this is to inject the bone edge because that's where the biology is. Those are where the cells are. You need to put into that optimal state to do the cell signaling. That's what this is all about. Here's an example. People say, oh, you can't regenerate cartilage. Well, here's an example. This is a woman in 2021. I injected her bone edge. She had loss of cartilage behind the kneecap. This is a side view of the knee. This reverse J is the cartilage behind the kneecap. So when you bend your knee, this kneecap glides along this curved surface along that cartilage edge. It's like the glider that your sliding door works in. She had prior surgery. She was read to be grade 2 to 3 out of 4. 4 is bone on bone. Chondromalacia means loss of cartilage of the meniscus, and grade 2 of the patella, which is kneecap. So we injected her in, I think, June of 21, and she did great. And it was about a year and a half later. I said, hey, I really could use some before and after MRIs. Would you do an MRI? She said, sure. So we injected her bone edge. We did not inject the joint because I was following that great work out of France. And the radiologist read back mild cartilage irregularity with mild thinning. They didn't even give it a grade. I said, okay, at worst, it's a grade 1. She went from a grade 2 to 3 degeneration to less than a grade 1. She reversed her cartilage degeneration, and we reverse degeneration. That's called regeneration. And now you can look at the thickness of that cartilage, that reverse J. Compare it to over here. It's at least twice as thick. She regrew that cartilage, made it nice and juicy. And how do I do this? Well, we do sedate people because no one likes a needle in their bone. And all the targeting is done off the MRI, and then in the surgery suite, in sterile conditions, I use fluoroscopy, which is an X-ray, and inject right into the bone area that we already know where to go. And it only takes me 10 minutes a joint or so. It's very simple. There's no downtime. You're up that day. You can exercise the following day, a little ice and Tylenol for a few days. And I do the same for the spine. Here's an MRI showing this white cranky area in the bone. This is the target, not the disc, the bone. We've been missing the target all these years and trying to treat the cartilage. To treat the cartilage, you got to go to the bone edge. So again, degeneration is not structural. It's metabolic. It's cellular activity. And this is cell signaling at its finest. And we do this without steroids, without drugs, without surgery. Yes, we do an injection under twilight. So this is all about longevity cell signaling, fighting inflammatory age-related degeneration at the cellular level. And we can help people with inflammation-related problems, autoimmune issues, hyperinflamed states. We can help them fight certain infections like long COVID and Lyme's disease, for example. This is all longevity cell signaling. Now, age itself, which contributes to all kinds of inflammatory diseases, and vice versa, inflammation contributes to age-related diseases because it's all the same, can also be addressed and reversed. And that's called inflammaging. And we love to help people fight and prevent problems. And we can use these exosomes for cosmetic purposes, bone density, sexual function, muscle mass, as I mentioned. But there's another form of cell signaling called peptides. And this is a growing issue where you inject yourself. And we do this, we now pair these with cartilage for cartilage regeneration. There are peptides for that, small proteins. And we use them for musculoskeletal injury and recovery, like BPC 157 and TB 500, the 1-2 punch usually used together. We know BPC 157 is 15 amino acids long, so its other name is the pentadecapeptide, but it's really generic because any 15 amino acids could be called a pentadecapeptide. But this is known to improve healing and collagen formation since the 90s. So why are we just now getting into it? Because it's naturally occurring. So a pharmaceutical company can't patent it. So we have to give it its own enthusiasm because we're not a big drug company here. And the early preclinical studies showed tendon, ligament, and muscle healing. People use this, athletes use it, I use it. No clear adverse reactions in tests. Tested up to 20 milligrams IV, and we never use that much, even subcutaneously. And again, it's found from gastric juice, and BPC stands for body protection compound, which is aptly named. Helps improve wound healing, enhances growth hormone receptor expression. So you inject it subcutaneous anywhere in the body. There are some gym bros who say, oh, I got a knee injury, I put it in my knee. That's ridiculous. It goes into your subcutaneous tissues of your knee, taken up by a capillary, taken up by a vein, to your heart, to your lungs, back to your heart, redistributed throughout the body. So that's the longest way to get it to the knee. The quickest way is get it to where blood flow is better, like the belly. So if you hear about these people injecting it locally, they're not doing any good. However, there's some recent evidence showing that BPC can be used inside of a joint, and we're now pairing that with some of my exosome injections in the bone edge. Now, some people say, well, can I just take a pill? You can, but if you follow the blue markings here on this graph, the bioavailability, meaning how much you get in your body, is extremely high, close to 90% with a subcutaneous injection. With an oral, it's probably 3 or 4%. If it's liposomal, you get a little boost. Maybe it's, I don't know, 10%. Intranasal, a little bit better than oral. Sublingual, useless. So if you're told you can take this orally, and there are a lot of companies who sell oral peptides, I know they're out there, nice people, but it just ain't getting in your body. You're going to have to take bottles of them. So we know BPC 157 is incredibly helpful. We know that TB 500, which is a synthetic version of a naturally occurring thymosin beta-4 fragment from the thymus gland. Now that also is anti-inflammatory and helps with angiomodulation, or help develop healthy new blood vessels. Incredible phase 1 safety data. You can use tons of this without any problems. Accelerates wound healing, and it's really great for cardiac repair after heart attack. I bet your cardiologist doesn't know that. Typical dose noted here, and you can cycle this on and off, as we do often with peptides, although some can be used at a lower maintenance dose. And we know this also, thymosin beta-4, also acts on articular cartilage chondrocyte work. So why would we use these in addition to our exosomes? So we can get even better benefit from our cartilage regeneration. But BPC 157 and TB 500 are often put together, and that's called the Wolverine protocol, like the comic book hero who can heal himself. And often there's a third peptide involved in those, usually KPV, which is also for neuroinflammation, really great to fight that. And GHKCU, known for its skin properties, but also works on an incredible number of longevity genes and anti-inflammatory genes in the body. And the rationale is you combine these, you're getting the best of anti-inflammation, angiogenesis, and healing all together. And these can be found combined in a bottle. And again, GHKCU is not just for skin use, and we also need to support our muscles. Muscles are a major longevity organ. Muscle mass is correlated with longevity. You could use MK677, or you can use growth hormone releasing hormone analogs like CJC1295, which increases the amount of growth hormone in the body. And you use it usually something called with DAC, drug affinity complex, which even prolongs its half-life. And you can also use this combined with the BPC, because BPC increases growth hormone receptors, and MK677 and CJC1295 increase growth hormone. So if you can increase the hormone and the receptor, you're getting a double whammy. Now you've heard of the morlins, ipamorelin, hexamorelin, samorelin, tesamorelin. These increase growth hormone release as well. Sometimes you find combos of them, sometimes in combination with CJC1295. And you know, you have to be really careful with these. If you take too much, you can hurt yourself. It's typically 3 times a week. You know, work with a clinician who can guide you on that. We also need to support our mitochondria and signal to them and signal to ourselves we care about the mitochondria if we want to fight towards longevity. So mitochondrial peptides like MOTC, which is a naturally occurring in our bodies. You release this when you exercise. Well, some people don't exercise enough, or they can't exercise because they're injured or something. MOTC can help you get that benefit to your body, signaling muscle gains and other health benefits, or even works in the brain. So that is a really important one and supports metabolic flexibility. Remember, longevity is adaptability. So even though diet, exercise, and aging affect MOTC, you can also supplement it. Okay, it has a role in bone metabolism. And that might be one you do 3 times a week. And we see people that take MOTC have improved blood sugars, improved blood pressure, improved energy, endurance, and stamina, may promote muscle mass. And again, it can be combined with some other peptides, assists in weight management and reduces inflammation. Remember, key for aging. Another mitochondrial peptide is SS31, which helps improve the mitochondrial membrane, which is known to be damaged from certain viral proteins like a spike protein. So people with long COVID, this is a go-to. And I'll often do this one first for a month, then go to MOTC to fix the inner workings of the mitochondria for a month. That's very typical. And we know SS31 helps fight kidney disease, improves diabetes, improves Alzheimer's progression, supports longevity, cardiovascular disease, brain injury. So it's improved older adult skeletal muscle, which we need, right? Longevity. So this one's a little pricey because of the dose, but well worth it. So for people with long COVID, I like to do SS31 first and follow that up with MOTC. Really struggling, cachectic, maybe recovering from something, follistatin or follistatin 344 fragment is a great way to help stimulate muscle. I use it in a very limited fashion. and it works by affecting the activin binding protein, which allows muscle to grow. Here's a particular animal that has multiple copies of the follistatin gene and has incredible musculature, right? Obviously bred for its meat. Cartilax is a cartilage building protein, a cartilage anabolic. I use this on my patients who are getting cartilage regeneration. But let's also look at protein and peptides involved in bone health, because remember, bone mass correlates with longevity. So we have the BMP family, bone morphogenic protein. I've used these in spine surgeries in the past, which I'm trying not to do, but it promotes both bone and cartilage formation, stimulates hair growth, reverses chronic kidney disease, and may have a role in treating cancer. It can stimulate new blood vessel development, kind of like a TB500. It helps prevent bone loss. If you're fighting osteoporosis, this might be useful, but is not used systemically, so we'd have to inject the bones, which I can do, obviously. Bone peptides out there on the market, there's one called Forteo that's a peptide that might be useful. That is systemic. It is an infusion, and that's well studied. There are some intranasal calcitonin, which is a hormone from the thyroid area that can be useful for bone growth as well. What about bioregulators? These are smaller, more primitive peptides, sometimes 1, 2, or 3 amino acids, like epitalon, which can help induce telomerase activity, which is for longevity. It's identified from the pineal gland. It's geroprotective, helps you live longer, and restores melatonin secretion, which is not just for sleep. It's a repair hormone, helps you repair DNA while you sleep, during the dark phase, during the night. Don't miss out on that melatonin. You need it. It's also useful, epitalon is also useful in retinitis pigmentosa and helps with pulmonary tuberculosis, would you believe? It's synergistic with thymolin, TB500. It's also improved cardiovascular mortality in patients with coronary disease. Does your cardiologist know this? There are studies, share the studies. It's also potentially an adjunct to musculoskeletal repair. And I usually do these subcutaneous. Some people do it nasal spray. So practically speaking, you put all these together, regenerative cell signaling through exosomes. We can pair that with the peptides that stimulate. So you have, just like amniotic fluid has peptides and exosomes, we can do the same. You can have peptides just for the musculoskeletal injury because they're a lot less expensive than exosomes. But if you really want cartilage regeneration, I would love to stack my exosome injections with BPC 157, hyaluronic acid, and some bone morphogenic protein potentially as needed, and some wolverine peptides. And then for anti-aging, we love a mitochondrial repair cycle. We love the bioregulators. If you have metabolic issues, need to lose fat, not just weight, but fat, we do look at GLP-1s. I'm a big fan of low-dose GLP-1s if you're already at the right body composition. If you need to add a little muscle and you're struggling, but you're doing the work and eating the protein and doing the high-intensity lifting and all that, then we might add one of those growth hormone secretagogues, one of the morelins. The goal here is to avoid surgery, avoid cortisone injections. They're not fixing anything. In fact, the recent papers showed a repeat cortisone injections actually make you worse in the long run. And of course, strategic supplementation, really good omega-3s, high dose, vitamin D3, the sun does not give you enough, probiotics, magnesium, melatonin, all these things, and plant-derived exosomes. We have incredible results with Longevex. And you've got to be able to follow the endpoints, body composition testing, MRIs of your joints, blood tests, you've got to be followed. So consider regenerative medicine if the peptides aren't enough. Hormone optimization is also a key element. And if it's not enough or someone offers you just a random stem cells without doing an MRI, you're in the wrong place. Cell signaling is improving rapidly. This is happening now. It's not the future of medicine. It's the now if you seek it. People have a big appetite for this. They want to know the root cause. They want to direct the treatment at the root cause, and they want it with fewer side effects and more natural compared to pharmaceuticals. So thank you for coming to my lecture, growing with us at Recelebrate. Will you be part of the now? I hope so. If you want to learn more, contact me, Dr. Jeff, at info@recelebrate.com, or follow us on any of the socials. We love meeting new people, and thank you very much.